Good day. Today I will report on bowel obstruction. Intestinal obstruction is the inability of the intestinal tract to allow for regular passage of food and bowel contents, secondary to mechanical obstruction or adynamic ileus. Intestinal obstruction accounts for approximately 15% of all emergency room visits for acute abdominal pain. Mechanical obstruction can be caused by either intrinsic or extrinsic factors and generally requires definitive intervention in a relatively short amount of time to determine the cause and minimize subsequent morbidity and mortality. Common causes of intestinal obstruction may be divided according to anatomic region, such as the duodenum, small bowel, and colon. In decreasing order, the common causes for the duodenum include stenosis, foreign bodies such as basors, which are gastrointestinal stones that are usually made of vegetable fibers, strictures, and superior mesenteric artery syndrome. For the small bowel, adhesions are the most common, followed by hernia, intussusception, lymphoma, and strictures. For the colon, carcinoma is the most common cause of obstruction, followed by fecal impaction, ulcerative colitis, volvulus, diverticulitis through the mechanisms of stricture and abscess, intussusception, and pseudo-obstruction. The key features of ileus is mild to moderate pain with a diffuse location, with mild distension with or without tenderness, and decreased bowel sounds on physical exam, possible dehydration on laboratory testing, normal imaging usually, and the treatment is observation and hydration. For bowel obstruction, the pain is moderate to severe. It may localize. There is mild distension, tenderness, and high-pitched bowel sounds on physical examination. There's leukocytosis on laboratory results. Abnormal imaging may be appreciated and treated with nasogastric tube and surgery. Adynamic ileus or paralytic ileus is more common but is usually self-limiting and does not require surgical intervention. Both large and small intestines may be obstructed by various pathologic processes. Extrinsic, intrinsic, or intraluminal processes precipitate mechanical obstruction. Differentiating small bowel obstruction from large bowel obstruction is important because the incidence, clinical presentation, evaluation, and treatment vary depending on the anatomic site of obstruction. Intestinal pseudo-obstruction or Ogilvie syndrome may mimic bowel obstruction. The normal bowel contains gas as well as gastric secretions and food. Intraluminal accumulation of gastric, biliary, and pancreatic secretions continues even if there is no oral intake. As obstruction develops, the bowel becomes congested and intestinal contents fail to be absorbed. Vomiting and decreased oral intake follow. The combination of decreased absorption, vomiting, and reduced intake leads to volume depletion with hemoconcentration and electrolyte imbalance and may lead to renal failure or shock. Bowel distension often accompanies mechanical obstruction. Distension is due to the accumulation of fluids in the bowel lumen, an increase in intraluminal pressure with enhanced peristaltic contractions, and air swallowing. When intraluminal pressure exceeds capillary and venous pressure in the bowel wall, absorption and lymphatic drainage decrease and the bowel becomes ischemic, so septicemia and bowel necrosis may develop. Shock ensues rapidly. Mortality approaches 70% if bowel obstruction has progressed to this degree. This sequence of events may occur more rapidly in a closed loop obstruction with no proximal escape for bowel contents. Examples being an incarcerated hernia and complete colon obstruction in the presence of a closed ileocecal valve. Small bowel obstruction is approximately 4 times more common than large bowel obstruction. The most common cause of small bowel obstruction are adhesions after abdominal surgery. Although in most cases several months to years have passed from the time of the previous surgery, small bowel obstruction may occur within the first few weeks after surgery. The second most common cause of small bowel obstruction is incarceration of a groin hernia. Other sites that occasionally are responsible for small bowel obstruction secondary to hernia include the umbilicus, femoral canal, and rarely the obturator foramen. Umbilical hernias are more readily apparent and occur in any age group. Obturator or femoral hernias are much less common. Elderly females are particularly susceptible to these hernias, which may present with femoral or medial thigh pain. Finally, a defect in the mesentery itself may cause intestinal obstruction. In the elderly population, adhesions and hernias are still common causes of small bowel obstruction, whereas carcinoma is the most likely cause of large bowel obstruction because of the increased likelihood of cancer as people age. Patients older than 60 years old are more likely to succumb secondary to complications of bowel obstruction. Bariatric surgery may be complicated by internal hernias after Roux-en-Y gastric bypass. Other causes of small bowel obstruction are much less common and generally are the result of intraluminal or intramural processes. Primary small bowel lesions include polyps, lymphoma, or adenocarcinoma. Hamartomatous polyps are common in Peutz-Jeghers syndrome. Polyps occur in patients between the ages of 10 and 30 years old and cause obstruction in about 40% of patients. An unusual cause of intraluminal obstruction is gallstone ileus. In this situation, a gallstone has eroded from the gallbladder through the bowel wall and can cause obstruction at the ileocecal valve. Signs of gallstone ileus include bowel obstruction and air in the biliary tree. Lymphomas may be the leading point of intussusception and present as small bowel obstruction. Basors are most commonly composed of vegetable matter or pulp, as mentioned earlier, and generally persimmons can cause this. Patients who have undergone gastrointestinal pyloroplasty or pyloric resection are most susceptible to intraluminal obstruction by basors. Inflammatory bowel disease and infectious processes, including abscesses, may obstruct the small bowel at various sites. Radiation enteritis should be considered as a possible cause of small bowel obstruction in patients who have undergone radiation therapy. Blunt abdominal trauma may cause a duodenal hematoma. This condition is seen in children as a result of lap belt use and may present as intra-abdominal pain and vomiting similar to other causes of small bowel obstruction. Visualization of the entire small bowel can be accomplished by capsule endoscopy. An important complication is capsule retention, with literature reported frequencies of 1 to 20%. Capsule retention can lead to obstruction and perforation, so patients with abdominal pain after capsule introduction should be carefully evaluated for this complication. Neoplasms are by far the most common cause of large bowel obstruction. Colonic obstruction is almost never caused by hernia or surgical adhesions and should prompt an evaluation for a neoplasm. Diverticulitis may create significant mesenteric edema and secondary obstruction. Stricture formation may occur with chronic inflammation and scarring. Fecal impaction is a common problem with the elderly or debilitated and may present with symptoms of colonic obstruction. The most frequent cause of large bowel obstruction next to neoplasms are diverticulitis and then sigmoid volvulus. Elderly, bedridden, or psychiatric patients who are taking anticholinergic medication are most at risk for volvulus. A history of constipation may precede the development of volvulus. Radiographic appearance is usually classic. It can extend into the T10 area or higher, and cecal volvulus may cause large bowel obstruction. There's a higher incidence of cecal volvulus in gravid patients. The site and nature of the obstruction and the pre-existing condition of the patient will determine the clinical presentation. Although some generalizations are possible, there are no components of the history able to predict small bowel obstruction. Almost all patients will have abdominal pain. Pain is generally crampy and intermittent. Pain of mechanical small bowel obstruction is often episodic, lasting for a few minutes at a time, and may be periumbilical or diffuse. Pain tends to be less intense and more constant in adynamic ileus. Proximal obstruction usually causes vomiting. Vomitus is usually bilious in proximal obstruction but is feculent in distal ileal or large bowel obstruction. The pain of large bowel obstruction is usually hypogastric. Other features that can present in an obstruction of the small bowel or colon include the inability to have a bowel movement or pars flatus. Constipation is a common symptom of bowel obstruction. Partial bowel obstruction, however, is often associated with regular passage of stool and flatus. Additional risk factors are advanced age and anticholinergic or tricyclic antidepressants, which depress bowel motility. Physical findings may vary depending on the site, duration, and etiology of the pathologic process. In small bowel obstruction, distension is the most reliable sign, and some distension is usually present early in the disease process. Abdominal tenderness may be minimal to severe and localized or diffused. Peritonitis causes severe pain. The abdomen may be tympanitic to percussion. Mechanical obstruction produces active, high pitched bowel sounds with occasional rushes. If obstruction has been present for several hours, peristaltic waves and bowel sounds may be diminished. Patients with an adynamic ileus may have some abdominal distension associated with diminished or absent bowel sounds. Localized or rebound tenderness may be a sign of gangrenous or perforated bowel, which requires immediate surgical intervention. Careful examination coupled with radiographic investigation will often distinguish bowel obstruction from ileus. Emptiness of the left iliac fossa has been reported to be a reliable sign of sigmoid volvulus. Organomegaly or masses may suggest a cause of the obstruction. The absence of stool or air in the rectal vault supports a diagnosis of obstruction and may aid in the diagnosis of bowel obstruction, but its presence does not eliminate a more proximal obstruction. A rectal examination may identify fecal impaction, rectal carcinoma, occult blood, or stricture. Consider a pelvic examination in women to identify gynecologic pathology causing obstruction. A vaginal pessary can cause colonic obstruction due to extrinsic compression of the colon. We consider bowel obstruction or ileus in any patient with abdominal pain and distension. Numerous other pathologic processes may also cause these symptoms, but additional evaluation guided by the history and physical examination may be necessary to confirm or rule out obstruction or ileus. Although any segment of bowel may be affected, low colonic obstruction is the most common clinical presentation. Radiographs may demonstrate a massively dilated colon with well-defined septa and haustral markings and very little fluid without air fluid levels. A CT scan is the most reliable diagnostic modality and offers the advantage of detecting mucosal inflammation and evaluating mucosal viability. We avoid barium studies because the patient may be unable to evacuate the barium. Laboratory studies usually include the CBC and electrolyte levels, the results of which may vary depending on the duration and site of obstruction and the presence of bowel necrosis. Leukocytosis of greater than 20,000 per millimeter cube or left shift should make one suspect bowel gangrene, intra-abdominal abscess, or peritonitis. Extreme leukocytosis at greater than 40,000 per cubic millimeter suggests mesenteric vascular occlusion. The serum amylase and lipase levels may be mildly elevated. Increases in hematocrit, BUN, and creatinine are consistent with volume depletion and dehydration. Other indications of the severity of obstruction and secondary complications include increased urine-specific gravity, ketonuria, elevated lactate levels, and metabolic acidosis. In the emergency room, flat and upright abdominal radiographs with an upright chest x-ray or a lateral decubitus view can be used to confirm diagnostic suspicion for bowel obstruction, severe constipation, or free air. Plain x-rays can also localize the site of obstruction to large or small bowel. However, if clinical suspicion for obstruction is strong, CT scan with oral and IV contrast is the imaging method of choice in the emergency room. The CT scan is extremely sensitive in high-grade obstruction, providing information not only about the presence or absence of an obstruction, but often its location, severity, and cause. In the presence of renal insufficiency or contrast allergy, oral contrast alone may provide sufficient diagnostic information. Most patients with small bowel obstruction may be successfully managed non-operatively, whereas most patients with large bowel obstruction will require surgery. For colonic obstruction due to malignancy, resection of the tumor has been the gold standard treatment. Self-expanding endoluminal stents can be used to relieve the obstruction and avoid emergent operation. Use of a nasogastric tube is often unnecessary and associated with potential benefit and potential risks. It should be considered in the presence of severe distension and vomiting. Local surgeon preference continues to dictate local practice with regard to nasogastric tube use. Vigorous IV fluid replacement is needed because of loss of absorptive capacity, decreased oral intake, and vomiting. We monitor the adequacy of fluid resuscitation by the response of blood pressure, heart rate, and urine output. Closed-loop obstruction, bowel necrosis, and cecal volvulus are surgical emergencies. We administer pre-op broad-spectrum antibiotics. There are many possible regimens. Monotherapy could be tazobactam piperacillin at 3.375 grams IV every 6 hours, ticarcillin clavulanulate 3.1 grams IV every 6 hours, or a carbapenem. If adynamic ileus is suspected or the diagnosis is uncertain, conservative inpatient management, including IV fluids and observation, generally is effective in allowing the bowel to resume normal activity and function. Any medication that inhibits bowel mobility should be discontinued. So, for the purposes of consolidation, intestinal obstruction is the inability of the intestinal tract to allow for regular passage of food and bowel contents secondary to mechanical obstruction or adynamic ileus. So, when it comes to its pathophysiology, normal bowel contains gas, gastric secretions, and food. There is intraluminal accumulation of gastric, biliary, and pancreatic secretions either due to a mechanical obstruction or adynamic ileus. So even if there's no oral intake, this can occur. As obstruction develops, the bowel becomes congested and intestinal contents fail to be absorbed. Vomiting and decreased oral intake follow. The combination of both decreased absorption, vomiting, and reduced intake leads to volume depletion with hemoconcentration and electrolyte imbalance and may lead to renal failure or shock. Common causes of intestinal obstruction are stenosis, foreign body strictures, and superior mesenteric artery syndrome in the duodenum. For the small bowel, adhesions, hernia, intussusception, lymphoma, and stricture. And for the colon, carcinoma, fecal impaction, ulcerative colitis, volvulus, diverticulitis, intussusception, and pseudo-obstruction. Ileus is generally mild to moderate in pain with a diffuse location. With or without tenderness, decreased bowel sounds, imaging may be normal. And for bowel obstruction, the pain is moderate to severe. Pain can localize. There is tenderness. There are high-pitched bowel sounds. There's leukocytosis. Imaging is often abnormal. So we usually look at the site and nature of the obstruction and the pre-existing condition of the patient because physical findings will vary depending on the site, duration, and etiology of the pathologic process. We usually do laboratory testing to differentiate any mechanical and dynamic sources of obstruction. And then for imaging, flat and upright abdominal radiographs with an upright chest x-ray or lateral decubitus view can be used to confirm the diagnosis. You can also do CT scan because you could look for mucosal inflammation in this way. Most patients with small bowel obstruction are managed non-operatively, but closed-loop obstruction, bowel necrosis, and cecal volvulus are surgical emergencies. And preoperative broad-spectrum antibiotics include tazobactam piperacillin, ticarcillin clavulanulate, and carbapenems. And that's it. Our source is Tintinalli's Emergency Medicine. Thank you.